Hello everyone, I am Kevri, a third year physiotherapy student, and my topic is cerebral palsy, the types of it in neurology. So, first of all, what is cerebral palsy? Cerebral palsy (CP) is a group of permanent non progressive motor disorders caused by damage to the developing brain. So CP primarily affects motor, muscle tone and posture, impacting a child's ability to control their body throughout the life. So its onset during early brain development. It could be prenatal, perinatal or postnatal. So what will it affect? The mostly muscle tone, coordination and motor skills. It is non-progressive, means brain lesion does not worsen over time, and symptoms and severity will vary widely between individuals. Now its etiology, so it could be prenatal causes, perinatal causes and postnatal causes. So first of all, prenatal causes. It could be intrauterine infections, hypoxia or ischemia, genetic and chromosomal factors, maternal illness, or toxic exposure. Then, perinatal causes: birth asphyxia, prematurity or low birth weight, neonatal stroke, difficult or prolonged labor. Then postnatal causes will be traumatic brain injury, CNS infection, could be meningitis, encephalitis, severe jaundice could be. And for the note, CP etiology is multifactorial. It means that it's not based on one factor or one etiology or one causes. It could be multiple. Now, classification of CP. So it first of all, based on severity level, it categorizes CP into mild, moderate and severe based on the degree of functional limitation and the level of assistance required for activities of daily living. Then topographical distribution. It classifies CP by the body region affected. Example, it could be hemiplegia, diplegia or quadriplegia. It guides physiotherapy focus and assistive device planning. Also, then motor function. Motor function could be separated into pyramidal or spastic and extrapyramidal or ataxic and dyskinetic CP. Then GMFCS. It uses 5 levels 1 to 5 to classify gross motor ability and independence. So now first, based on severity classification. So first one is mild CP. The individual can move independently and perform activities of daily living, ADLs, without significant limitations. Motor difficulties are minimal and may affect the fine motor skills or gait slightly. Then moderate CP. The individual requires assistive devices such as braces, orthotics or medication to perform ADLs. Functional mobility is present, but it is limited. Physical and occupational therapy are essential. Then severe CP. The individual will be in wheelchair dependent and faces significant challenges with ADLs. Requires extensive support for mobility, self-care and communication. It will be multidisciplinary care for critical. Then based on topographical distribution, it could be monoplegia or monoparesis. So it means one limb will be affected only. Then it could be diplegia or diparesis. It means that primarily both legs will be affected and arms will be less involved. Then hemiplegia or hemiparesis. It means that one side of the body, arm and leg will be affected. Then paraplegia or paraparesis. It means that both lower limbs will be affected. Then triplegia or triparesis. It means that 3 limbs will be affected, usually both legs and one arm. Then double hemiplegia. It means that both sides will be affected, upper limbs more involved than lower limb. Then tetraplegia or tetraparesis. It means that all 4 limbs affected, legs more than arms. Then quadriplegia, quadriparesis. It means that all 4 limbs equally affected with severe involvement of trunk and neck. Then motor classification. As we said earlier, it could be pyramidal, means spastic CP, or extrapyramidal / non-spastic CP. What happens in that? Increased muscle tone, hypertonia, hyperreflexia, and spasticity caused by damage to the corticospinal, means pyramidal tract. Most common type includes spastic hemiplegia, diplegia, or quadriplegia. Then extrapyramidal / non-spastic CP. It could be ataxic CP. It means that cerebellar damage causing poor coordination and balance. Dyskinetic one, it will involve involuntary movements, could be athetoid or dystonic. Then mixed CP. It will be combination of spastic and non-spastic features. Then gross motor function classification system. So there will be level 1 to 5, as we discussed earlier. Level 1 will be walks without limitations, means runs and jumps, but speed and balance may be reduced compared to the peers. Level 2 will be walks without assistive devices indoors, but with limitations outdoors and in the community. And level 3 will be walks using a handheld mobility device, example crutches, walker, may use wheeled mobility for longer distances. Level 4 will be self mobility will be limited, so it will use powered wheelchair or is transported by others in most settings. Then level 5 will be severely limited self mobility. Dependent wheelchair user requires assistance for all transfers and positioning. Then clinical use. GMFCS guides surgical planning, physiotherapy goals, and assistive technology selection. Then it's brain damage correlation with CP types. So as we discussed earlier, it could be pyramidal and extrapyramidal. So both systems we will discuss the damages of it. So first one we will do is pyramidal one. In that, damage to the corticospinal / pyramidal tract causes increased muscle tone, hyperreflexia, and spasticity mainly. So it could be spastic hemiplegia, spastic diplegia, spastic quadriparesis. So in hemiplegia 1, unilateral and cortical subcortical lesion will be there. In diplegia 1, periventricular white matter damage will be there, very common in immaturity. In quadriplegia, extensive bilateral cortical or subcortical injury will be there. Then extrapyramidal 1. So in that, damage will be the basal ganglia, cerebellum, or their connections causes involuntary movements and the coordination deficits. So it could be athetoid, dyskinetic, dystonic, and ataxic mainly. So in athetoid, basal ganglia will be affected, the lesion, example hypoxia. In dystonic, basal ganglia and thalamic both will be involved, and in ataxic, cerebellar damage causing imbalance and coordination impairment. Now spastic subtypes. So spastic hemiplegia and diplegia. Then spastic monoplegia and triplegia. Then spastic quadriplegia. It is the most severe spastic subtypes associated with widespread cortical damage, intellectual disability, and bulbar dysfunction. Highest dependency for ADLs and mobility. Then there's also triplegia and diplegia also. Then other CP mixed forms could be dyskinetic CP, ethetoid subtypes will be there, dystonic subtypes will be there, ataxic CP will be there, and hypotonic CP will be there also. Then mixed CP types will be there. Could be spastic plus ataxic, could be dystonic plus ataxic, flaccid plus dystonic. So for the not mixed types increase clinical complexity and requires individualized physiotherapy management strategies. So it will be hard to treat mixed forms. Thank you, and these are the references.